organisation of King's College Hospital, Guy's of St Thomas's Hospital, South London and Maudsley Trust, and the University of King's College London.
And hello, my name is Emma Konstantara. I'm a PhD student working in eating disorders in type 1 diabetes. And today I will be taking your questions on the chat function.
Thank you. Sorry, Alan.
My name is Alan Wickes. I'm a patient with type 2 diabetes.
Thanks, Alan. And we're also joined by Omar. Do you want to say hi?
Hi, I'm Omar Mustafa. I'm a consultant in diabetes and general medicine at King's College Hospital, and also I manage a training program in South London for endocrinology and diabetes.
Great, thanks everyone. Just to note, if we don't have a chance to answer all your questions, we can try to answer them on our social media outlets afterwards, or they'll help us inform future topics. So we'll talk about it later on. So please do put all your questions to us. And now I'll hand over to Khalida. Thanks, Khalida.
Thank you again, Rebecca. So just to tell you a little bit about these webinars, for those of you who've joined us new, these are live sessions for people with diabetes online. And when we say that they're interactive, that means we're talking about you. We need your comments, your questions, because this is for you to tell us about what it's like living with diabetes from a psychological point of view. This is not a venue for providing specific clinical advice. So if you've got any urgent concerns, please do contact your GP or your diabetes team. So as you've realised, our topic today is on attitudes, and this is quite an interesting psychological concept. It really refers to a position we take, an attitude, a position we take regarding our thoughts, feelings, and the way we behave, usually about something. And today it's obviously about diabetes. So that's going to be our overall theme today, but obviously it's linked to other psychological processes. So I'd like to welcome again Alan Wickes. Thank you so much for joining us. And you said that you're a patient with type 2 diabetes, but perhaps you can actually tell us a little bit more about yourself. You are actually a person. You know, how old you are, what do you do for a living, where do you live?
Okay, so yeah, I'm 60 years old. I had diabetes for my 45th birthday, which wasn't quite what I was expecting. Currently, I'm working as a holistic assessor for the Access to Work program, but I've had a varied career. And so originally my life started off as a producer, and then I moved over to the charity sector, working for a small charity where I did the social media and all things internet-based. Yeah, so I've had diabetes, type 2 diabetes for 15 years.
Right, okay, so you've led, and where do you live about? Whereabouts do you
I live near Crystal Palace.
Oh, right, okay, so you get the view of the tower?
Not from my direction, no, I get a view of Wembley.
Okay, wow. Yeah, we forget how hilly South London is, don't we? So you mentioned, you know, it must have been quite a shock to be diagnosed with type 2 diabetes at the age of 45. What you said, it was a shock. What were the kind of thoughts and feelings that went through your head at the time?
I think initially I was kind of quite happy to have a diagnosis, because I'd had so many, you know, the being thirsty for quite a long time, and nothing would the kind of hangover feeling, and nothing would get rid of it, and therefore at the time the diagnosis was a relief. But then I suppose over the next few months, I suppose initially you try quite hard and you are kind of wanting to fight it. And I think after 6 months or a year or so, I think that kind of runs out a little. And I think that I became more apathetic. But then when things weren't going so well again, I think I kind of rediscovered that really I needed to kind of get involved and take up the fight almost, and become more engaged with obviously, and whilst it looked great on the plate, obviously it wasn't doing anything for my blood sugar. So I had to kind of change my diet, do more exercise. And that's when I decided to get involved in clinical research, because I thought, well, you know, we need people to do clinical research if we're going to get, if people like me are going to get out of this. We all just sit there on the sofa and eat the cake. It's going to lead us nowhere. And therefore I decided, that's when my involvement in diabetes research started. But also, when I started to cycle more and lose some weight and try and develop a more positive attitude. I still try and keep that positive attitude going. And obviously some days are better than others. I'm certainly, as you can see, I'm not the smallest person. But I blame the camera for that.
So thank you. That actually sounds like a very interesting psychological journey in your relationship with your diabetes. I was really struck by the different phases that you describe. And I think that I'm curious about the people who are listening, whether they would describe similar phases, and I'll go over them in a minute, or whether they get stuck at a certain phase in coming to terms with diabetes. So I think this is a really common one, isn't it, where you're just relieved that you know what the problem is and that you actually start feeling physically better. So there's that sort of relief phase where you're being also cared for. And then I was quite interested in, you sort of had the initial sort of fighting phase. And you described two fighting phases. One is the first one, which is very upbeat.
That's right.
And then becoming quite fed up and apathetic, perhaps when you realised that this diabetes is here to stay.
Indeed. I think once I read about it more, and I think it's the kind of dawning realisation that it's kind of here to stay, and therefore, you then have to make the best you have. That you make of it the best you can, really. And that's when I decided to, like I say, get involved and try and do more about it and try and understand the condition more, because I think in understanding, it's easier to fight it.
So that we'll come back to the understanding and knowledge in a moment, because that's really important. And I think what I'm really curious about is what helped you to move from the apathetic, I can't believe this is here forever phase, to I've got to do it, it's in my power to do something about this. I'm going to try and do something about it, because a lot of people get stuck at that moment and can't quite see that they can get better.
I think it's just reading more about it, and I guess, just reading and coming across more information, and obviously by doing more information and coming across more research and the things that people are doing, it inspires me in a way to do more, because I think it isn't just about taking the tablets, it's about yourself taking control. And I think that is kind of possibly the best thing, is the wrong thing to say, but it is an aspect of diabetes that you have a degree of control yourself, and therefore it's time to get off that sofa and try and do a little bit more, and try and resist all those foods which aren't going to do you any good. Try and stick to a low carb diet, because ultimately that's going to improve things. And obviously cooking wise, it is a challenge at times, but then it's sometimes a welcome challenge, because it's you're not going to stick to the same food all the time. I've played around for years for trying to make a low carb, low sugar Nutella, and failed generally quite miserably, but I will try and try again.
Excuse me for my sneezing. That's, how would you actually describe your attitude then, since this is the topic? What would you say, what kind of position have you taken towards your diabetes?
I suppose my attitude is to always try and be good, try and stay positive. And you get good days, you get bad days, like anything. And I think it's a bit like my hair. Some days it's kind of all over the place, and other days it stays quite happily flat. And it's the same thing with diabetes. Some days you're very much in control. You check your blood, or you feel okay, and things are going well. And other days things are going really badly, and you go and see your friends and they present you with potatoes and all these other foods, and you have to say, well, I can't eat the potatoes, or I don't want to eat the potatoes, and therefore you get these little conflicts, restaurants and meeting friends, and that's when you have to kind of that's when you have to kind of think to yourself, well, I have two options here. I eat the food here, or I'm going to say, no, I can't eat it, or it's not for me. So yes, certainly, there's always little challenges along the way, but it's, as time goes on, they get easier because you share it with more people. And the first thing they say to you is you can't eat sugar, but it's not really, that's a small part of the spectrum.
Yeah. I was very interested in how you describe that you always, your attitude is somebody who will keep trying. I mean, would you say that you have a conscientious attitude towards your diabetes?
Yes, because it doesn't go away, and therefore it has to be in your mind. I think you have to, yes, you have to be conscious about it all the time. Yes.
Yeah, and I guess just going back to the people who are listening, who have got diabetes, who know somebody who's got diabetes, I'll be very interested in our chat function, what adjective you would use that describes your attitude towards diabetes, or if somebody that you know who has diabetes, what their attitude is, because I think this sort of can help us think about what our relationship with diabetes is and whether we think that's a good quality relationship or not a helpful relationship, and whether we want to change our attitudes. And I think one of the things, Alan, that you're showing is that one can keep changing one's attitude towards diabetes as life goes on, and it's a bit of a journey. And you've described periods of being low. Can you tell us a little bit more about when things aren't going so well?
Oh gosh, I guess when your blood sugar's high, or you go to the doctor and you get your results back, it's never the greatest feeling to know that you think you've been doing quite well over the past few months and you blatantly haven't. But having said that, tomorrow's another day, and therefore you have to start again. It's just because you've had the wrong food that day, or the wrong meal, or the wrong, too much chocolate or whatever. The next day is a new day, and therefore you have to go back and have another go. You don't get, it's completely wrong to abandon all hope and give up, and to become apathetic about it. And personally, the medication developed is amazing, but you also have your own self and your own ability to fight it. And therefore, I think, you should, help yourself effectively.
What we're saying is that a person with diabetes, you can be your own doctor, you can be your own drug.
Yes, to an extent, yes. I think obviously with Google, if you type anything in, then you will find the answer you're looking for, which is kind of right and wrong. So therefore, I think you have to be very careful about the advice you find on Google. But for sure, you can. But with eating healthily and eating low carb options and doing a little bit more exercise when possible, it will all help.
Yeah.
Whereas the staying on the sofa is doing no help, and huge amounts of snacking and eating the wrong food will only make things worse.
And what about, you've had a very checkered career doing lots of different things. You've been quite active in the diabetes community. You've mentioned being involved in quite a lot of research as a person with diabetes, that you actually contribute to the development of research projects and so on through your patient role. I mean, you must have met lots of people with diabetes, and what kind of different attitudes have you come across?
When I lived in Streatham, I was the chair of my local local surgery, and I once had a general chat to one of the patient group meetings that was going on, and I came across a lot, because it was advertised locally. I came across quite a few diabetics living locally, and it was quite sad to come across some of the attitudes then, because they had failed to kind of understand the simple steps people can take to improve things for themselves. And I don't know whether people need like a yearly reminder of the things they can do, and the food swaps you can do, but it was quite surprising. I have to say, when I go to St Thomas's for my yearly eye check, to walk into that reception room and see all those people with missing limbs and realise that is the result of poor diabetes control, I always think that's a real wake-up call. But I guess if you don't get to see that, or don't get to understand the long-term complications that diabetes brings with poor control, then you continue to do the eat the wrong things.
But I think you highlight something really important, Alan, because I think people do, I mean, you're describing a number of different scenarios, really. There are some people who, what you're saying, who don't want to find the information or haven't realized that they should find the information or that the information is there. They've sort of put the onus on taking the tablet and the diabetes will go away, and they're keeping it that simple because perhaps that's their level of understanding and that's not necessarily their fault. It's perhaps the way the information has been handed over to them. But you also describe the scenario of, for you, the fear of getting a complication is enough for you to take action.
Yes.
But I have met many patients where the fear of complications actually makes them go into more denial.
Yes. Yes, I do often say that the D in diabetes actually stands for denial, so it's type 2 denial. But yes, I mean, it's a whole range of things, isn't it? It's lifestyle, it's anxiety, it's stress, it's, you know, there's a whole range of elements, you know, involved in blood glucose. It's just how you, and in terms of transmitting that information over to patients, it's tailoring it to them or tailoring it more towards their understanding of what's going to work for them. Because some people will need, you know, a lot more information. Some people just need bullet points.
You do highlight how hard work it is, don't you? That
indeed, yes.
It's not like some other conditions where you take a tablet and actually, as long as you keep taking the tablet, everything will be okay. I mean, diabetes requires so much more from you, doesn't it? It's like you said earlier, it's not just about taking a tablet. It is about changes in lifestyle.
Yes, definitely.
That is forever.
Indeed.
And what you say is that you go through good phases and bad phases, but what is really positive about what you say is that when you're going through a bad phase, you try to focus on tomorrow is another day.
Yes, yeah, and also, I mean, there are foods, and you know, but also when possible, obviously, current conditions, it's great to get outside and do some exercise. You know, either walking or cycling or whatever works for you. It's lovely to be outside, walking around the park, and you know, and I think you have to kind of, it's not just, you know, eating the dreadful food, you know, people diabetics. There's lots of recipes out there and lots of things to play around with, and I quite enjoy playing around in the kitchen and trying to make edible food. I think it's always a challenge for me. But it certainly brings challenges, but that's, you know, without the challenges, life is less, I think. You always need a bit of a challenge. So
you mentioned, we've talked about people's attitudes towards diabetes. You've obviously met lots of health professionals, and we have got a doctor here, Omar Mustafa, will be talking to us later. But have you come across different attitudes of health professionals towards you and to other people with diabetes?
Yes, I mean, I've obviously obviously in my role as a patient representative, I have, but also as a patient. And I think that I think sometimes healthcare professionals are a little worried to say to people, well, have you thought about losing some weight? I think that's a real kind of killer question, really. And I think people are very nervous about saying that question to people. I think in case people take offence, you know, because weight loss will help. You know, it will, and there's no other way to kind of say it other than how about losing some weight.
It's okay for diabetes professionals and GPs to actually be quite directive with patients and say, have you thought about losing a bit of weight? You think that's the elephant in the room that we don't talk about enough?
I think it is because, and also I think from, you know, psychological aspects, I mean, people generally do feel better when they lose weight, both physically and sometimes mentally. I'm not suggesting people, you know, lose weight rapidly or you know, lose it. But if it's lost in a controlled manner, you know, and possibly with the help of their, you know, GPs, then I think it's a good positive thing. And people generally feel better about themselves, you know, when they are a little bit lighter. I'd like to lose a few pounds. So
that's a really good point. If you had to give people with diabetes your personal sort of top tip of what you've learned that's helped you look after diabetes from a psychological point of view, what would you share with us?
Be positive, stay happy, and work out what makes you happy. You know, whether it's listen to music, because you can listen to music when you're outside. You know, you can, stay active, and don't give up.
Yeah.
Don't give up.
Trying.
Definitely keep trying. Don't give up.
Yeah.
Be good. Be good.
Thank you. So don't go away, because
I won't.
doing some of the questions and answers will be coming back to you. So I'd like to now welcome Dr. Omar Mustafa. Thank you again, Omar, for being patient and joining us. I know you've been busy on the wards. So would you mind telling us a little bit about yourself? Like, where did you study medicine? How long have you been a doctor? And why did you choose diabetes?
Thank you. Well, I've been a doctor for a little while now. I trained in medicine. My undergrad training was in Iraq. I did some work there at junior doctor level, and then I came back to the UK, where I had my postgraduate training. I rotated through several places, several rotations, and then finally settled at the Southeast Thames training program for endocrinology and diabetes. And I've been at King's as a specialist registrar since 2011, and then as a consultant since 2013. And my particular area of interest in diabetes is type 1 complications and type 2 and complex type 2, as well as a big chunk of my interest is inpatient diabetes. Outside of clinical medicine, I have a particular interest in health professions education and how can that support people with diabetes and care of people on the wards and in hospital.
Omar, can I just ask, have you got your video on?
I don't actually. Let me double check. Oh no, it's not on. Should I put it on?
I think we'd all like to see you.
There you go.
Thank you. And so what was it like studying in Iraq? I mean, that's, we always think of it as a war zone for the past sort of 30 years.
Indeed, yeah. Well, the period I studied medicine in was in the 90s. So it was sort of in between wars, sort of a low-level, high-intensity type situation, because at the time, in the 90s, there was the economic sanctions, so studying medicine was not the easiest, as is life in general. But you go through it, you learn how to make the best with the best available resources available to you. And I finished training in 1999, and in end of the 90s, beginnings of the noughties, where I started my training. So again, I faced the same situation of, well, we have to do the best for the people who are coming to hospital or needing emergency care, that have relatively limited resources and not much access to advanced treatments, because there's not much coming out from elsewhere, even to the point of you can't even consult with anybody outside the country. So it's a difficult situation, but you learn.
Yeah, a bit like what we're doing now with COVID-19, the amount of adaptations that we've all made, and it's pretty incredible that we can do them. So how did you end up in diabetes?
Sorry?
How did you end up in diabetes?
I had, during medical school, I had sort of 2 or 3 specialities in mind. And then I started my training, it was very broad-based training, then settled on doing general medicine. And what attracted me to endocrinology and diabetes was the holistic nature of the systems. It's not organ-based, so there are multiple sites in the body, but it has a very holistic, generalist approach. And you're dealing with people rather than a single organ or a single cell, depending on how much specialist you are. And then you're dealing with other it interacts with a lot of other specialities and healthcare professions, which makes it very interesting.
Mm-hmm. Yeah, I think that seems to be a recurrent theme from all the diabetes professionals that we've been interviewing, is the bit that they like about diabetes is the science of a condition that affects the whole body, And so you have to talk to the person rather than the organ or the cell, and you get to work with so many other people from different specialities, don't you? So, so our topic is on attitudes, and you talked about, that your areas of interest is complex type 2 diabetes, type 1 diabetes, and education. And let's start off with people with diabetes and their attitudes, and we'll move over to health professionals. What have you observed in terms of attitudes? Different categories of attitudes. How have you learned to categorize them when you meet people with diabetes?
I think each person is different, and what I'm increasingly learning is actually the way you come across is important, and having the open approach to people's issues and problems is key to try and understand where they come from. And therefore, if I think traditionally people look at a condition and say, well, those people will have 1, 2, 3, 4 types of approaches or how they can present, which to some extent is an easier way for healthcare professionals to try and understand diseases, conditions, tests, lab results. But I think dealing with a person as a whole is key to try and understand how you apply the advances in medicine, the advances in lab tests, diagnostics, therapeutics, to get the best outcome for that particular person. There is a role for looking at a bigger picture, and that's when you're planning, when you're doing your services. But again, you really need to have that individual approach would be key to success, because that person will be with you in the room.
So I guess when we think about attitudes, sometimes you might pick up whether somebody's got a positive attitude towards their diabetes, or a laissez-faire attitude towards their diabetes, or a really negative attitude, like angry or dismissive, or fed up. And what have you picked up in your clinical practice, and which ones have you found is helpful?
I quite often, particularly if I'm seeing the person for the first time, spend quite a long time trying to understand where they come from and how did they come up to the conclusions. And sometimes you start with those sort of phrases of, well, the person may have a statement and go, well, I am very angry about X. And then you start to dissect that statement, or I am very upset about Y. And that may actually completely take you into a different path. And you slowly start to dissect that. And actually, sometimes 3/4 of the conversation will actually be about non-diabetes things. And then you understand who they are, where they come from, what they do, how's that impacting. And then lastly, you go, okay, so, well, how's that impacted on your diabetes? And that depends on what setting you do it. The more complex, the less often you see the people, the more issues you pick up.
Yeah, I was really impressed with what you've just said, that actually a lot of your consultations may involve, or a big bulk of your sessions may actually involve, allowing the person to ventilate, to describe their emotions, to share their emotions, their frustrations with their diabetes, and giving them that space to do so seems really important for you to then be able to come back and say, now let's talk about the practical aspects. That's a very powerful strategy that you use, and it's really lovely to hear that that pretty sounds like you might almost be a psychiatrist.
Yeah.
And what have could you give us some examples of having worked with patients where that working has led to better outcomes for the patient? You don't need to give us any names or anything like that.
Of course. I mean, as simple as, for example, someone comes in and they're completely upset and angry because they can't walk. They have a lot of pain. And then you start to dissect, okay, well, let's look at where the pain is. And then the pain turns out to be very painful diabetic neuropathy. And then you explore what brought that on. And then that actually as a result of very high blood sugars, or because they have been upset as a result of losing their job, they haven't been able to organize their bring their medications, do the right visits, and healthcare attending healthcare settings, attending appointments. The more problems you have becomes more problematic. So all that can be quite overwhelming. So you start from one problem, which is pain, and actually you end up looking at a much wider aspect of that. And by addressing all of this little bit at a time, and so sometimes it's very tempting to look at everything in one setting, and you tend to have the immediate problems trying to resolve, and then you look at the bigger picture. And actually that person came in 6 months down the line, and he was very happy and things were sorted out. I didn't sort out all his problems, but the trying to understand and signpost and work with the other specialists did a lot of help for that particular person. Actually, his diabetes management was probably about 30% of the actual changing doses and tweaking and adding new therapies.
Yeah, they're often the smallest part of your work, isn't it? It's just making sure that the patient has been understood, and that you are making sure that the different aspects of that care is happening is often your role. So if you had to give, how has your work changed during COVID-19? What has been your day-to-day life been like for the past 4 weeks as a doctor at King's, which is one of the largest numbers of COVID-19 cases in the country?
Sure. So the proportion of my inpatient work has completely overwhelmed outpatient. So my general medical commitments has become pretty much 90% plus of my day-to-day work, compared to about 20-30% what it used to be. I don't have outpatient clinics anymore, so I'm all going to the ward, doing night shifts, day shifts, looking after wards. And that was also an opportunity to actually look at the bigger picture for those people who came in with COVID-19, plus people who dealing with COVID-19 as a condition is one aspect, but also people who have multiple other conditions and got COVID-19, and how do you optimize that to give them the best outcomes. And the second aspect, which increased significantly during the COVID-19, is inpatient diabetes, because we've had a significant change to how inpatient diabetes is delivered. There's more cases. We had much more numbers of people presenting with diabetes, acute diabetes presentations, high glucose, ketoacidosis, certain presentations of type 2, new presentations of diabetes. So it's a huge change, a huge shift, much different workload, but also we have to factor in changes in how workforce work, more virtual work as much as possible, and trying to protect your staff and your safety will be key here. So it's very different.
A lot of different new ways of working to juggle. If you had to give one sort of like general top tip from what you've learned as a diabetes professional to people with diabetes about how to support themselves, is there any suggestions or tip that you could give?
I think safety first, and adapt to what comes along, because by adapting, it keeps you up to date and it keeps things in perspective. We all like to have things run according to what we like, but these conditions don't often happen. So staying safe and adapting is key to survival.
Being flexible, and thank you. So we're now going to move, please don't go, we're going to move into our chat function and hand you over to Emma, who is going to read out some of the questions. Thank you, Emma.
Hi, we have a question from Kathy Eastburn. Would you like to turn on your camera, Kathy, and ask your question? Hi.
Kathy?
Hi. Thank you so much. This is the first time I've been to one of these. I found out about it from my GP practice, who texted us today about this. So I really appreciate it, and I will be back. I wanted to ask a question about COVID-19 and diabetes, which is that I've been type 1 diabetes. I'm 52 and I've been type 1 diabetic since I was 17. And since the beginning of, well, pre-lockdown, I've been basically self-isolating at home with my family, my husband and 2 teenage daughters. And as a type 1 diabetic, I come into that kind of, not the top category of at risk, but that kind of second tier of vulnerable people. But I'm aware that quite often diabetes is used as a very catch-all, broad brush category, and it encompasses people who might be very unwell at one end and people who might be super healthy, and I'm super healthy at the other end. And it kind of, this is pre-COVID even, I sometimes feel that it's used as a sort of almost like a broad brush category, and I would like to get behind that and find out more detailed information about the risks to me as a rounded human being, not just lumped in with this very broad category of all kinds of diabetics. I'd like to read up on it and be able to make more informed decisions about what I should be doing, not doing, what the risk factors are, etc. So I'm just wondering if you can signpost me to anything, I know there's no research yet into COVID-19 and diabetes, obviously, it's too soon, but the public health information must be based on research that is considered relevant. And I'd like to be signposted to that research so I could really like dig down and drill down and find out more and make my own informed decisions.
Thank you, Kathy. And I think from a psychological point of view, what you're saying is this broad brush treatment of all people with diabetes into one category creates quite a lot of anxieties within the diabetes community because you don't know which category you really belong to, and that anxiety is not good for your isn't good for your well-being, is it? It just creates more stress and more. So Omar, thank you. That's why we have a diabetes professional on our program, and it'd be great if you could just perhaps say where there'd be some good signposting. I know that things are developing, and we recognise that this is important.
The evidence is increasing, and the more you read, on a daily basis, you'll find more. I guess a good starting point is Diabetes UK. They have built a page where there is an ongoing updating of the evidence for people with diabetes. I mean, even for us as healthcare professionals, if you read the literature, there's so much coming out to the point where prior to COVID, there was a lot of peer review, there's journals going through lengthy peer reviews. Nowadays, because there's so much coming out, there's a lot of evidence being produced that's yet to be scrutinized. So actually, even for us, when we look at evidence, you have to be really careful and what does that mean for the person sitting in front of me. The evidence generated by Public Health England, again, it's in the same place, it's evolving. Quite a lot of it was probably based on previous models, and that's how you evolve the evidence. And based on newer data, you continue to build a more specific models. And as COVID-19 is new condition, a lot of the models were based on other infectious diseases and other expertise in that phase. So and I agree with you that a broad brush model doesn't work for everyone. The general view is that diabetes is a condition where glucose is high, and that's the definition of diabetes. But there are, as you say, there's a wide range of people with different conditions, different status of disease, and therefore it's difficult.
Yeah. So, Kathy, I hope that is helpful, that as a starting point, Diabetes UK and Public Health England will have the latest summary of information. But I hope you also recognise that even the diabetes professionals aren't 100% sure. So we're both in the same ballpark, but it does sound like that people who've got type 1 diabetes, who've got very good control of their diabetes, are generally not as risk. Is that right, Omar? people who might have really high sugars?
Yeah, so the latest so far, our understanding is there is a sort of a binary division of if the HbA1c is high, and the current cutoff is, according to the latest study, is 58, and that is 7.5% in old money. Above that, the risk is higher. We don't know how high. Below that, the risk tends to be lower. However, the advice still stands that people with diabetes should follow the risk stratification so that they can actually shield from the condition until there's a vaccine or treatment.
Okay, thank you, Kathy. Emma, have we got any more questions to share?
Yes, we do. So Mario has asked, how does anxiety and stress influence your blood sugar levels?
Anxiety and stress does bring your blood sugars up, and that is all the mechanisms generated by anxiety and stress are normal mechanisms to fight or flight, and therefore these tend to push the blood sugars up. The longer the anxiety, the higher the blood sugars. And people, for example, if they have a more dynamic way of monitoring their sugars, sensors, or they can see it, and that tends to be quite significant in some people than others.
And Alan, you're the person with diabetes. What you can tell us from literally a lived experience of how does diabetes and stress affect your blood glucose levels?
Sorry, Alan, you're muted.
Sorry about that. It certainly raises them, and therefore, if I do find myself getting stressed and anxious, I then try and do a bit of exercise, because I find cycling distresses me, or I go for a walk, and I try and monitor far more carefully the food I'm eating until I'm less stressed. But yes, it's always a juggling act, because obviously, different events in your life create stress.
Yeah. And I'm always interested about how stress affects and anxiety affects diabetes, because there's one is the cortisol response. Is that right, Omar? That when you're stressed, you get a cortisol response which releases more glucose from your muscles, because that's the original flight-fright response. But also when you're stressed, you might comfort eat, or you might take your eye off the ball in checking your blood glucose levels or giving the insulin, because you're a bit preoccupied with whatever else is stressing you. So it's very interesting and very complicated, and people can be quite harsh on themselves when they're going through a bit of stressful time and their blood glucose levels change. They sort of blame themselves rather than acknowledging that their external world is a bit stressful at the moment. Would you both agree with that?
I mean, cortisol is one of them. It's probably more a second response. You do get the adrenaline, noradrenaline, catecholamines type response, and that's the first thing that kicks off. And then you'll get the cortisol with more chronic forms of stress. And both of these, tend to mobilize glucose into the blood, because that's what you need if you see a lion in front of you.
Yeah, well, we all have to stay alert at the moment, don't we? So there's going to be higher levels of anxiety and stress in all of us, in the way our nervous system is wired up. Thank you, Emma.
Okay.
There is another question for you, Khalida. So during lockdown, Darren has noticed that he is more frustrated and jealous than before. How can one deal with this?
Frustrated and
Jealous. I guess it is more rise of negative feelings than before, isn't it?
So, thank you, Darren. I think that's a really common emotional experience during lockdown for quite a lot of people. So I think there's an element in which you have to accept that this is a normal reaction, even though it's a reaction. And there are some really useful, the fact that you even recognize it is really, the first step is really important, is to know that you're getting stressed, which is what I noticed Alan said, that when I'm stressed, I recognize it. And then I try to solve that problem of being stressed by either exercising or listening. I think I don't know if you mentioned music, but exercising, going on is fine.
Yeah.
I think Darren, you know, what you have to do, and this is for everybody really, so this isn't clinical advice specifically to Darren, but to all of us, is that when we are stressed, is to acknowledge it, you know, ventilate it, tell somebody about it, tell yourself about it, write on a piece of paper, and then think about what normally you find relaxes you, which is again what Alan was saying. So think about the normal strategies that you do that help you unwind. But there are also some really lovely tips on the NHS website about how to do relaxation. There's deliberate muscular relaxation techniques that we can use, and if we haven't sent you them in the toolkit, we can put them on our Twitter and Instagram page, because we've come across quite a few that we like. We always think talking to a friend or a family member is really important, so eliciting the support systems that you already have are also really important. So, you know, there are also helplines around. So if it's around diabetes, you know, you've got diabetes, you get a fantastic helpline. So there are a number of strategies, and thanks for raising that up, because we can actually send a bit more information through our social media channels.
And I guess we have time for one last question, and the rest will be answered on our Twitter. So there is some uncertainty on what do people with diabetes have to do after the second governmental announcement. Has anything changed for them? Do they have to change what they're doing? Can they go out? Are they safer than before?
Mm. So that's a, you know, that's an interesting point, isn't it? Because it's a practical question about their safety, and I guess what they're saying is that this is causing some anxiety around whether they're out to go out. So maybe Omar could perhaps help us, if you've got an understanding of what this latest announcement, people with diabetes, who have been in lockdown or in shielding, are they allowed, you know, what does it mean for them?
That's a difficult one. I think the shift now is moved from lockdown everyone to try and ease some parts of the economy, some parts of the population. I guess the emerging evidence so far is probably that you really still need to be careful. I don't think it's a license to go out and do what we used to do. So I would still advise people to keep activities that they think to an essential rather than what is desirable to do, because we're still in an uncertain time of what does that really mean to have the virus around, but not much. I think we're still seeing deaths, we're still seeing much lower number of cases, but I think the virus is still around. So I don't think easing the lockdown means lifting the lockdown, as some newspapers may have put it.
Yeah, and it'd be interesting to ask Alan how he has interpreted it, because you are a person with diabetes. How have you interpreted the latest announcements?
I think where possible, you still have to stay home and you know, and try and keep, you know, remember to social distance when you are out and about. I think that's the really big thing. And I do believe that if you're going to travel on public transport, you should wear a mask. I think other countries are doing that, and you know, if you know, bigger and smaller countries do the mask thing, and therefore I think it's a good idea to do it when possible. Lots of things online how to make a mask. I've got some beautiful examples of homemade masks and some appalling ones, as you can imagine. But yes, why not wear a mask? Yeah.
So I suppose the bottom line is, for the person who asked the question, is basically stick to what you were doing before the second announcement.
Yeah.
And we get more specific guidance, isn't it? And remain careful. So thank you very much, Emma, and to all of you who've been asking the questions. I'm now going to hand over to Rebecca, who's going to share this week's new toolkit.
Hi everyone, I'll just share the slide with you so you can see. A few resources we'll recommend this week. Don't worry about writing it down, I can share it on the chat and our social media afterwards. So the first one, if you're not already aware, is the Diabetes Online Community. There's their Twitter handle there. They have a tweet chat every Wednesday, 9 to 10 p.m. We've hosted it a few times. It's a really fun chat, a really great way to speak to other people with diabetes. So check that out if you haven't done so already. The next one doesn't really relate to our theme, but as it's tonight, we thought we'd point you in this direction. But it's a webinar on diabetes technology. It's on at 6 p.m. and it's with Dr. Bill Polonsky and Adam Brown. And I'll post the link as well, so you can access that if you'd like to. And some research, I thought we'd point you in the direction of some research related to diabetes attitudes. So the Dawn 2 study, if you have a look at that, that can point you towards some diabetes attitudes research. Thank you.
Great, thank you, Rebecca. So we've got a few minutes left and just wanted to ask Emma if there were any last questions that people wanted to ask.
Yes, there is one. Let me just read it. So it is about the long-term, oh, you can hear me, the long-term effect of diabetes and coronavirus actually on the health of people with diabetes.
So could you say that again? I didn't quite catch it.
Yes, so let me actually just read it straight away from the way they sent it. So if COVID is around for a long time, what will be the impact on people with diabetes with ongoing and prolonged precautions?
Well, it's probably, there will be an impact, won't there? You know, this is, we can't, people with and without diabetes can't maintain this for a long time. So what do you think, Alan and Omar? Alan, if you had to stay in lockdown for another 3 months, say, or for the rest of this year, what do you think it would, how it would affect you?
I don't think it'd be great. I think, yes, I know people who are on the vulnerable list and have had the letters to stay inside. Yes, I think it would have a huge psychological impact on myself to stay in. I have been out once or twice, so it's always nice to kind of get some exercise and go outside. But I think, you know, if you take precautions and are careful, then there's no reason why you can't go for a walk, get some forms of exercise. And it does help to get out, for sure, I think. And especially if you don't have access to gardens, and if you're living in a flat, then you need some space, you need some outside space. It's only natural to go outside, I believe.
I think that's, yeah, I think that's really sensible advice, Alan. Omar, what's your perspective on what we're asking our people with diabetes to stay in lockdown?
I think it's similar to the general population. I'd say it's stay, you know, keep the social distancing, keep interactions to minimum, and stick to the essential list until we are absolutely certain this is no longer a risk. There is a huge need to adapt, and we all adapted to doing things very differently compared to what we used to do. And I think hopefully we might have a vaccine or treatment, and this may look very different. Science advances very quickly, so let's see.
Great, thank you. So we're going to end our webinar here now, and thank you very much for joining us. Just to tell you a little bit about our topic next week is fear of hypoglycemia, and we have we're very pleased to have an actress with type 1 diabetes who will be talking about her work in acting, but also with her we will be doing a demo, maybe a couple of demos, on some psychological skills based on cognitive behavioral therapy on how to address fear of hypoglycemia and other anxieties and worries of diabetes. So look forward to meeting you then, and thank you very much for your attention. Bye. Thank you, Laura, and thank you, Alan and Emma and Rebecca.
Thank you.
Bye.